تفضلي يا دكتور.
Dr. Magy, it is my great pleasure to present Professor Dr. Magy. Dr. Magy is a very active professor in Gaucher disease and in hemophilia, which has many publications international and participation as well in international conferences. And now she's going to give us a music piece of pulmonary involvement in Gaucher disease and treatment options. Please, Dr. Magy.
Thank you, Dr. Ahmed, for the very, very kind introduction. And thank you, Dr. Mona Falki and Dr. Hala Hamdi and all the organizers for giving me the opportunity to participate in this unique event. Actually, the organization is great and it's very innovative. Actually, I'm going to present this topic because it's very important to know that though Gaucher disease is a rare disease, yes, it has many common presentations. And one of these presentations would be as recurrent wheezy chest or recurrent chest infections. So if we don't think Gaucher, we will not diagnose Gaucher. And in spite of having around 300 patients diagnosed and on ERT, yet still Gaucher disease is an underdiagnosed disease in a population like ours with over 100 million with a high rate of consanguinity. I'm going to go very briefly through the prevalence of Gaucher disease and then afterwards the pathophysiology, highlighting the pulmonary involvement and the treatment, whether of Gaucher disease or pulmonary involvement. It's not working. It's not working. Okay, thank you. Okay, as we see here that Gaucher disease is the most common sphingral episode in lipidosis that was first described by Philippe Gaucher in 1882. And very interestingly in his thesis, so I hope currently that our thesis also will highlight such important findings. He described an unusually appearing cells in the spleen of a 34-year-old woman who presented with splenomegaly. Afterwards, neuronopathic Gaucher was recognized in 1927, and it was not until 1934 that we knew the underlying biochemical basis of the disease. Very interestingly, we conducted a study in our inborn error of metabolism unit where we found that Gaucher disease constitutes 48% of sphingal episodes in Egypt. Gaucher disease classically has three phenotypes, depending on the absence or presence and severity of neurological signs: the type 1 non-neuronopathic, the type 2 and 3 of the neuronopathic. But the demarcation between the neuronopathic variants is imprecise, and it's more accurate to consider such phenotypes as a continuum of disease, ranging from extrapyramidal syndrome in type 1, as we will see later, at the mild end to hydrocephalus at the severe end of type 2. Regarding the prevalence, it ranges from around 1 to 50,000, but it can be up to 100 to 850 among individuals of the Ashkenazi Jewish population, to less than 1 per 100,000 live births in the neuronopathic variants. So, as you can see here in this figure, I'm not sure if that is working or not, so I won't use it, okay? The type 1 constitutes around 95%, whereas the neuronopathic, whether the types 2 and 3, they constitute around 5 to 6%. Very interestingly, type 3 has a very high prevalence in the Far Eastern population in China, up to 55.2%, with the highest prevalence in Egypt, up to 71%. Now, regarding the pathophysiology, mutations in the GBA1 gene, which is very specific to Gaucher disease and has been linked recently with Parkinson's disease, and this is very important, it leads to a markedly decreased activity of the lysosomal enzyme, the glucocerebrosidase. Sorry, it's not working, okay? The glucocerebrosidase here, and as you can see that the glucocerebrosidase enzyme, we will break down the glucoside ceramide into glucose and ceramide. Now, what is happening here at the other end is that the monocytes are maturing to macrophages in the marrow or in the liver, the Gaucher cells, or in the spleen, or in the lung, which actually we will focus on today. Once these macrophages are resident, they would accumulate the glucoside ceramide by phagocytosis, and as you can see here, they would form the end-stage Gaucher cells with the eccentric nuclei. Regarding the phenotypic spectrum, you will see here at one end, patients that can be asymptomatic, especially in type 1, or presenting with bone or visceral and hematological manifestations at one end, or at the other end, the very severe hydrocephalus. And in between is the type 3 or the neurological manifestations of the type 3 Gaucher disease. Now, actually, I thought to make this figure to highlight the 3 phenotypic presentations. And what you can see here at the extreme right is that all 3 of them, whether the GD1, GD2, or GD3, present with hepatosplenomegaly, bicytopenia, bony manifestations, or growth delay. However, regarding the GD2, patients would have a very severe neurological disease, with neck rigidity, spasticity, squint, bulbar symptoms, especially in the form of dysphagia, pyramidal, extrapyramidal. However, regarding the GD3, they would have the hallmark of Gaucher disease type 3, supranuclear gaze palsy, due to oculomotor paralysis. So the patient, when he would look to the extreme right, left, up, and down, he would compensate with head thrusting. Also, they would have a variable degree of cognitive impairment, seizures, squint, bulbar, and we have really, for the first time, reported the phenomena of sudden unexpected death in epilepsy and abnormal behavior in our cohort. Now back to the lung. The most prevalent pulmonary manifestations would be in the type 3. So, lung involvement, by the way, this is a high-resolution CT of one of our patients showing the ground glass failing. Lung involvement in the Gaucher is often associated with severe and sometimes fatal morbidity in patients with GD3, and especially those homoallelic for the mutation L4B, which is the commonest mutation worldwide and in our cohort. Clinical and radiological evidence of lung disease can appear as early as 2 years of age before the neurological symptoms, and this we interpose here, and can be misdiagnosed as atopy or asthma. It can even start as early as the age of 6 months. The response of lung involvement to enzyme replacement therapy is unpredictable, with the general experience being that pulmonary manifestations have been slow to respond or even worsen despite ERT. The more severe lung complications can end up to hepatopulmonary syndrome and even in children. Pulmonary hypertension is quite variable and can be up to 12% even the pediatric age group. Now, I thought that figure on the extreme right can really highlight the 3 main abnormal manifestations of lung involvement. That would include the pulmonary parenchyma, or the lung parenchyma, in the form of interstitial lung disease, as we can see there, or the chest wall in the form of deformities and fibroscoliosis, as we will see later, or the pulmonary vasculature in the form of pulmonary hypertension. Now, regarding the signs and symptoms, and this is actually the vision chest of one of our patients, patients can be either asymptomatic, yet they would have interstitial lung disease in up to 70% on high resolution CT. They can have cough, dyspnea, recurrent chest infections, recurrent wheezy chest, and they can be hospitalized, and in few cases, they can be admitted to the ICU, unfortunately. Regarding the imaging, the most common, as we said, is the interstitial lung disease, but they can be ground glass veiling, as you can see here, bronchiectatic changes, air trapping, and mediastinal lymphadenopathy, and that's a very interesting finding. Also, the patients would have increased pulmonary blood pressure. Now, regarding treatment, unfortunately, is up till now mainly symptomatic and supportive, with bronchodilators, antibiotics, or oxygen therapy and vasodilators for the pulmonary hypertension. Now, the pathogenesis, diagnosis, sorry, it's just the time. Gaucher disease diagnosis is based on clinical signs and symptoms, as we saw before, family history, and it's confirmed by laboratory assays. Again, please, bone marrow aspirate is non-specific. Once the diagnosis of Gaucher disease is suspected, beta-glucose reductase activity in total leukocytes or mononuclear cells or cultured fibroblasts is measured. This is because low enzymatic activity is the gold standard for the diagnosis. And the residual enzyme activity is usually approximately 10 to 15% of the normal value. Now, regarding the diagnosis of GD3, again, it's based on neurological abnormalities, plus or minus genotype. For example, if we have the commons, that's the homozygous L4-4P, for the neuropathic Gaucher, I cannot say that this patient has type 3 unless they have neurological abnormalities, and we would start with the supranuclear gaze pulsing. Serum carbohydrate is used to monitor treatment efficacy and can be used as a prognostic marker, and this is very important. Now, regarding the assessment of the pulmonary infection, it's either initially or on follow-up, or when required, for example, when the patient is hospitalized, that would be by chest X-ray, high-resolution CT, and echocardiography. Treatment of Gaucher. With regard to treatment, the first question we confront is who to treat. Treatment should be given to all children with GD1 and all those with GD3, whether they are neurologically asymptomatic and diagnosed by genotype or sibling of confirmed type 3 patient, or are symptomatic. The second important issue in treatment is multidisciplinary approach in the management of those patients, with ERT currently being the gold standard. And actually this was published by Dr. Bushleri. So, as you can see here, this is the treatment in a nutshell, which we will expand on a little. Now, the enzyme replacement, it's either the first prescribed enzyme, actually most of our cohort are on this ERT, it's the amiglucerase or the Serazyme, and it's recombinant and has marked beneficial effects on visceral and hematological disease in type 3, but its effect on existing neurological signs and their progression is a subject of great debate, though we noted that in our cohort. Also, there's the beliglucerase alpha or the BP-RARE, as well as the teliglucerase alpha. Both have been approved for type 1, but we are using the beliglucerase alpha for type 3 for the visceral and hematological manifestations. Now, regarding substrate reduction therapy, there's the miglustat, and it reduces the glucose riboside formation, as the name implies, by decreasing its production. It's an oral preparation that crosses the blood-brain barrier, and it's approved for patients with mild to moderate Gaucher disease. When ERT is no longer accepted by the patient or can no longer be used due to intolerance. It's effective in reducing the size of the liver and the spleen as reported, as well as decreasing the carbohydrate level. However, it has significant side effects as diarrhea and weight loss, but these generally regress with the reduction of treatment or cessation. Eliglustat, and we have now around 400 patients worldwide on eliglustat. It's again a glucoside-ceramide synthetase inhibitor indicated for the long-term treatment of adult patients with type 1. But this is very important. They have to be CYP2D6 extensive metabolizers, intermediate metabolizers, or poor metabolizers detected by an FDA-cleared test. Also, we can use a combination of ERT and SRT, especially in patients with pulmonary involvement, lymph nodes involvement. Bone marrow transplantation is used to be used at one time, but it's no longer used because of the cost benefit and because of the high prevalence of side effects, especially the graft versus host. Regarding the pharmacological chaperones, this is a new strategy to increase residual protein function by stabilizing misfolded mutant proteins. So it prevents the endoplasmic reticulum-associated degradation in proteasomes and allowing trafficking to lysosomes. The most importantly and currently used is the ambroxol, and we are also using the acetylcysteine, and it's quite effective in the seizures as well, both the ambroxol and acetylcysteine. It's not known exactly how this works. Regarding the gene therapy, there have been several trials, but it's still at the basic research level. Now, systematic and supportive and adjunctive management options would include the blood transfusion, we hardly ever now do a splenectomy because it's reported that it can worsen the neurological and blood manifestations. However, regarding the lung disease, we give patients antibiotics, whether through pediatric or prophylactic, bronchodilators and mucolytics, especially the acetylcysteine. Now, this is one of our patients, and she has, as you can see, as she has grown over the years with the recent development of hyperscoliosis and mesenteric lymphadenopathy, unfortunately. You can see her in the picture. So she's a 10.5-year-old girl who presented at the age of 11 months by recurrent wheezy chest. Then abdominal distension was noted accidentally. This was associated with vulvar symptoms in the form of dysphagia, which is what we usually encounter, head thrusting, anorexia, and easy fatigability due to her marked pallor. And she was transfused at the time. She had a low beta-glucose ferrosidase and a high serum chitotricidase. The patient was started on 60 IU per kg every 2 weeks of amiglucerase. At the age of 2 years, the chest symptoms became more frequent, unfortunately with monthly episodes. More severe in winter, but the patient was not hospitalized. She was maintained on prophylactic bronchodilator and nebulizers during the attack, and really that was enough. Last severe chest episode was at the age of 7 years. The chest symptoms were associated with severe vulvar, and both showed vulvar symptoms, and both showed marked improvement simultaneously. And you can see here the round glass veiling and the bronchiectatic changes. Now, regarding this patient, this is the patient at the age of 11 years showing hyperscoliosis, hepatomegaly, and the splenectomy scar that you can see here, and spread after, unfortunately, 10 years on ERT. Now, this is his current photo at the age of 70 years. The thing is, with hyperscoliosis, unfortunately, at the teenage period, there is rapid progression of the hyperscoliosis. And it's not always associated with the deterioration in the pulmonary functions or in the chest condition. But unfortunately, with this patient, this was the case. So he's a 17-year-old young man who presented with motor delay initially and organomegaly. That's what we typically encounter in all our patients. He was diagnosed at the age of 1 year and received ERT for 10 years with very few chest complications, unlike our first patient. He then started to develop chest infections that recurred every 2 months of variable severity because of his progressive hyperscoliosis, as well as uncontrolled seizures and accumulations of secretion. He was admitted to hospital twice in the past 2 years with severe pneumonia. However, I have to thank really the CF team, cystic fibrosis team, because they helped us in his management, and because of this, he's doing really so well now. His last pneumonic episode was 2 years ago, and it lasted for 3 weeks, where he received intensive therapy in the form of antibiotics, bronchodilators, steroids, and expectorants, usually the acetylcysteine sessions. He's maintained on prophylaxis and showing significant improvements. Prophylaxis regarding his bronchodilators, antibiotics. This is his chest CT, multi-slice CT chest, showing the pulmonary interstitial disease, their trapping, and the early parabronchial bronchiectatic changes. In this patient, it's stationary. In their previous patient, it was regressive. Sorry, I couldn't point here because it's not working. So, take-home message. Lack of disease awareness, overlooking mild early signs as recurrent wheezy chest, recurrent chest infection in an infant, and failure to consider Gaucher disease in diagnostic differential were considered major barriers to early diagnosis. This led to Gaucher earlier diagnosis consensus with logarithm of major signs and covariables for non-specialists, and actually hopefully this publication will be coming up soon. Enzyme assay is the gold standard for diagnosis, please, okay? Because if we don't do the enzyme assay, these patients will be misdiagnosed. Supranuclear gaze palsy is the gold standard of neuronopathic Gaucher, as I explained before. Recurrent wheezy chest and chest infections can be the initial presenting symptom in Gaucher disease patients, especially GD3. Multidisciplinary approach is mandatory in managing GD patients, and I think in managing all chronic patients and pulmonary patients or patients with chronic lung disease. Thank you. Gaucher disease team. I saw Monica was